the webinar and begin the webinar.
So thank you. Good evening to all of you. Welcome to this webinar on Art of Survival with COVID. As you all know, COVID-19 has turned out to be a global pandemic. Within a blink of an eye, COVID-19 has posed great challenges not only to the physical health, but also has potential to drain out the mental and economical health of the mankind across the world. Actually, it is not so much about corona COVID-19 virus. It is the fear about it that has caused this great damage to the world. I would like to extend a formal thanks and welcome to the speakers, very distinguished speakers today, who have gracefully accepted our invite to deliver the talk and also answer some of the questions our community, IIT Guwahati community has. So we have a faculty, students, and all the families, because this program is also beamed live on YouTube. This program is being live on YouTube. Many of them are watching this program on live. It is not just the people who have logged in into this program here. So let me take and thank the speakers of today, Professor Kevin Dhaliwal, Chair, Molecular Imaging and Healthcare Technology, Honorary Consultant in Respiratory Medicine, Dr. Sumit Sengupta, Pulmonologist, AMRI and Fortis Hospitals, Dr. Sayantan Banerjee, AIMS Delhi. Thank you so much for accepting our invite and being with us today to enlighten us on how to survive this COVID-19. Thanks also to Dr. Sakadal Saha, Professor of IIT Guwahati. You heard him before, what he was talking about IIT Guwahati and his friends. It's really amazing. I completely agree with him. And all the support from IIT Guwahati side, administration side, is there. We really look forward to interact with you, not just this seminar, even further on the healthcare. And we would like to create a School of Health Sciences and Technology very similar to IIT Kharagpur. So we require your help. We are moving in the direction slowly, but it takes some time. I know, because there is a lot of differences between running an engineering school and a medical school. And thanks also to Professor Dipankar Bandopadhyaya, very young, energetic, but very forward and a simple person who is heading our Center for Nanotechnology, which is second, because I come from Indian Institute of Science. Last 27 years, I spent my time at IISc Bangalore. And last one year and 1 month time at IIT Guwahati. I will tell you, our Nano Center at IIT Guwahati will be #1 in 2-3 years time, not just #2.
Thank you, sir.
And as of all of you know that IIT Guwahati is the only IIT this year has improved its ranking in every ranking, and particularly our chemistry department is 6th in the world in the Nature Index. So I don't want to take more time here to tell about that. So, but I look forward for the and also very fruitful discussion after the lecture. And this webinar, as I told you, is beamed on YouTube simultaneously, so that large number of our students who are across India can watch this and also be comfortable, because we are bringing them back to campus. They started coming back, particularly research scholars are started coming back. So I take this opportunity once again to thank all the speakers and also Dr. Sakadal Saha to make it happen, and I welcome all of you also to this webinar, and look forward for the interaction with the speakers. Thank you all. Again, I don't like to take more time, so thank you so much. Have a great day and look forward for the lectures. I will be there in the lectures completely. Thank you.
Thank you. Thank you.
Thank you so much, sir. Akshay, please. Thank you, sir. I think I'm sure that we would have a very fruitful time ahead with this webinar. We have 3 speakers. We have a team of global experts. We have 3 speakers. The first speaker is Professor Kevin Dhaliwal. He hails from University of Edinburgh. He is a pioneer in molecular imaging, healthcare technologies, and pulmonary healthcare technologies. So he heads the chair of molecular imaging and healthcare technology at Center for Inflammation Research in the University of Edinburgh. He is the honorary consultant in respiratory medicine. And more than anything else, he is in the forefront as a COVID warrior, helping the UK government in addressing the challenges posed by COVID-19. With he has a very decorated career. With no further introduction, I request Professor Kevin Dhaliwal to address the webinar. Professor Dhaliwal, please go ahead.
Yeah, so thank you very much, and for the honour to present here, and lovely to meet you all virtually. Hopefully one day we can meet in person. So I'm just going to upload some slides quickly, just to make sure these come up. 1 minute. 2 seconds.
Hi.
Please bear with me 1 second, the talk is just loading. So as the talk is loading, I'll just continue talking while it's just about to come up. But so first of all, yeah, thank you again for the opportunity to speak. So I'm going to talk about just introduction to COVID very shortly, but then really summarise our local response and our thoughts about moving forwards, and in particular around how we're thinking the drug pathways, but also healthcare technology more broadly to address some of the challenges that we're now facing. And then hopefully at the end in the question and answer, we can go through some of the other key areas. So as low as, sorry, apology, the talk is still loading at the moment. I think there's poor bandwidth on this side. In 2 seconds. So I come from Edinburgh, the University of Edinburgh, Scotland. And as you all know that as introduced, COVID-19 is and has been a pandemic, and it's sometimes hard to see when it will end. But the UK was hit relatively early on in terms of the upsurge. So as China first emerged, then South Korea and other parts of the world, and then Italy, mainly mainland Europe, and UK. Okay, 2 seconds. So it hasn't loaded, so I'll keep talking while the slides are uploading. But the UK really was hit quite early on after Italy and mainland Europe. And essentially what happened was that we now know that most of our imported disease came from mainland Europe, so really France, Italy, and Spain. So we've sequenced this. And we know that that's what happened. And the UK government decided initially not to. So we actually decided that we would stay open for as long as possible because they're worried about the economy. Unfortunately, that had the effect that it did allow the virus to spread very quickly. And so the UK shut down probably 2 weeks too late. And by that time, that point, the virus had been spreading for maybe 4 or 5 weeks from the United Kingdom. And then we really did see an overwhelming of our healthcare services quite quickly in terms of the intensive care facilities. So for a small country, such as the UK, we suddenly saw large cases flooding in and intensive care units having to shut down very, very quickly. So that really meant that the UK has been shut down for quite a while, and it's just reopening now at the moment. And what we're now seeing is what other parts of the world are seeing, which are small surges or little spikes that are occurring as we haven't controlled the virus. And that's what we're facing now, which are, as we've unlocked, we're seeing spikes and actually local lockdowns are having to occur, and they're just starting to happen. But what did happen was a very large research effort started in the UK to try and understand the disease and also develop novel therapies for the disease. So we understand a lot more about COVID-19 SARS-CoV-2 clearly than we did at the beginning. And what we're hoping to do is be prepared for future waves, but also to hand the knowledge as fast as possible to other parts of the world. So again, let me just try and load this again. I'm sorry about this. It must be either this side or your side. 2 seconds. So we started a program. Okay, just bear me 1 second. Sorry about this. So, okay, can you just give me 2 minutes? Sorry about this. It's just it looks like this for some reason the web is not allowing us.
It's okay.
Yes.
It's okay, Kevin. Okay. Go ahead.
Yeah. Yeah. Just give me 2 seconds. So for some reason, I'm gonna let's try this again. Let's try this again one more time. If not, I'll talk through the talk. Can you see me trying to upload here on your web portal? No.
Not yet.
Oh yeah. Okay. Okay. So trying to upload once more. So as I continue on, so the UK saw a rapid upsurge, and what we saw were healthcare systems being quickly. What we also saw early on was what we now know is there's a lot of asymptomatic carriage. That means that people can transmit the disease without having any symptoms whatsoever. And so what's really been hit in the UK has actually been the care sector, so care of the elderly in care homes. So at least 50% of the deaths have actually occurred in care homes where there wasn't adequate personal protective equipment, and patients were moved very early on into the care homes. And what we've learned really, hospital sector, is that the vulnerable are patients that are typically over the age of 50 and have comorbidities. That means people have other diseases or other underlying diseases. And the most common risk factors turned out to be obesity, hypertension, chronic kidney disease, as really the three things that really show a poor outcome measure if you develop severe COVID-19. Now, in terms of symptoms, typically patients get the virus, and roughly about a week later, 7 to 8 days later, is when they potentially can develop lung complications. And that was what we saw as being the major drain in our healthcare systems, were patients presenting at day 8 to 9 after getting the infection, and then presenting with fulminant, as we call severe lung injury and lung failure. That really has pushed us to try and develop novel therapies to help protect the lungs as much as possible. We set off many trials and studies to try and mitigate against that. And many of the therapies have been shown to be ineffective. But one study that was run in the UK actually showed a survival benefit, and that was actually dexamethasone, which is a steroid. So it is now common practice to now introduce steroids in week 2 of patient care to try and stop the inflammation that's causing damage to the lungs. So what we're trying to do now within Edinburgh and across the UK is really to develop some of those technologies and therapies and understand what's happening. So in Edinburgh, we've been driving for the technology aspect. Can you see that now? Is that presenting?
Yes, yes. Okay. Please go ahead. It's visible
very quickly. So just go back. Just now I remember my talk very quickly. Is that what we have learned through COVID-19 here in the UK and abroad, that no matter what happens, it must be achieved through teamwork and unifying, and no other, I suppose, in our lifetime, nothing else is going to happen at this pace, which required us all to work together. This is a dashboard taken about 3-4 hours ago of today, really in terms of giving a snapshot of where we are today. So when we say 21 million global cases, that's confirmed with a diagnosis. Clearly, many, many more people have been infected without a positive test. Roughly 760,000 deaths, but again, that's probably an underreporting because people aren't always reporting this on their actual death certificate. But really, the hotspots currently are now the US, Brazil, and as you're all aware, locally with yourselves in India at the moment, but then Russia and South Africa again are now increasing in numbers. And really, this is a CT scan showing what happens in week 2. The arrows are pointing to where there's lung damage and injury occurring, and it's trying to understand what's happening there and trying to stop that happening, which is a major focus of the world's attention. And just thinking about how we've been developing treatments, really there's the first phase, which is the viral response phase, where antivirals could work, but the second phase, which is where the host inflammatory system kicks off. And that's really where most therapies will work. And that's why, as discussed, a steroid has been shown to have an effect. The natural history of this disease is that people get sick when either they're unable to control the virus at the beginning, or when inflammation, that's your body's response to how it controls infection, actually becomes excessive. It does too much of it. And that's something that's not clear of why that's happening in people. Clearly, the drugs don't work at the moment. Some of the early trials have failed, or some of the trials have shown very, very small benefits. So really what needs to happen now is new trials need to happen, and they are happening across the world and in India with mechanism. And this is just a table showing you lots of different potential drug trials and all the numbers on the side. What's clear is, though, what is needed are large coordinated trials rather than lots and lots of individual trials to get the answers. Here in Edinburgh, we've been trying to bring this together, trying to bring technologists together from both chemistry and engineering to try and understand what's happening deep inside the lung, as well as trialists that can develop studies and bring drugs to patients. So we can fuse the engineering physical sciences with the clinical science to try and understand what's happening deep inside the lung. So our technology typically has been around trying to actually visualize deep inside the lung, so making the invisible visible. And what we're trying to do is actually develop novel chemistries that can pick up some of these pathways. Don't worry about the names. These are fancy names for inflammatory processes occurring deep inside the lungs. But we're actually trying to make multicolored probes that we can then deliver deep inside the lung and actually start seeing deep inside the lungs. On the left, you have an imaging system. On the right-hand side here, those round things are actually seeing deep down into the lung. And what we're hoping to do is then actually start doing optical molecular biopsy. So we actually start pushing these fibers deep into people's lungs and seeing what's happening by delivering local chemistries. And the idea is then we'll actually just start imaging deep where we think things are actually happening. So this is a video of actually deep inside patients' lungs where we're seeing inflammation happen in real time. So what we've been doing is pivoting our research. We had existing research with technology, but also clinical stuff. And we've had to pivot it all into COVID-19 focused research, really because of where we were before, but what we need to do now with urgency. So from our perspective, we've been launching a program called Stop COVID, where we try to understand what's happening. That's called Cascade and IceCap. We started to develop this idea of experimental medicine, where we actually give drugs, both in the hospital and the community. We've accelerated a chemistry and engineering team to come together, and we're creating an industry academic cluster to think about solutions. And the relevance here, we're also developing an innovation partnership locally here with digital solutions, try and think of some of the other challenges that SARS-CoV-2 and COVID-19 have been we're facing. So sampling wise, we're doing things just taking bloods every day to understand what's happening in the lungs and in the blood of patients. And then also very hard to do, but something we have set off in Edinburgh is actually doing, unfortunately, post-mortems to understand what's happening in the lungs so we can develop novel therapies. So patients who do have SARS-CoV-2 and then referring them and then taking next of kin authorization and then actually performing warm post-mortems as fast as possible, trying to understand the disease. What we're learning there is actually some of the key variables that occur. We're taking samples from all over the body and taking, so excuse this gory picture of the lungs, and actually visualizing really what's happening deep down in the lungs and trying to understand from a virus perspective and a host response what is happening so we can think about which drugs we put into patients. And so as part of this is a UK platform. Ours is called Define on the right-hand side. We've unified across the UK. Edinburgh is one of these where we're trying to trial novel drugs in this disease. And these are just a list of drugs, but on the right-hand side are the ones that we're doing, the Famostat and Camostat. Now, the other thing we've done is also thought deeply about some of the health tech and innovation to support the National Health Service. And we identified 4 challenges. One was around slowing the spread. The other was about enabling home-based care, supporting the well-being morale of the healthcare service, and actually assisting those most vulnerable and self-isolation. So thinking about technology communication systems that could come in and help these patients and people in the public domain. We're passionate about working with India. We have linked in with the task force repurposing drugs for COVID-19. And actually 2 of our drugs that we're taking are also being taken forward in India. So we're partnering with institutes across India who would like to take forward some of these drugs, and also thinking about how we could transfer knowledge of some of our initial surge that we had here for public health measures and testing. But again, if we come back to this slide that we have here, the pandemic, we're in the midst of a pandemic. And as you said, as was introduced, the one thing that has happened, there has been fear. What is clear is that many people are completely asymptomatic, have mild disease and are well. So it's important to be able to identify those patients at risk so we can look after them, identify them, and let the rest of society unlock. I mean, that really has to be the use case moving forwards. But again, the last slide again, just saying a big thank you for allowing me to speak here today. And sorry about my slides, but this is all about teamwork and working together with a vision that only together, working across continents and also disciplines, can we tackle COVID-19.
Thank you, Dr. Kevin. So we will come back to you again during the panel discussion session. Amongst us, we have another reputed pulmonologist who also practices respiratory medicine and specialized in it, Dr. Sumit Sengupta. So he's a MD, MRCP, FRCP, and CCST. He's a noted pulmonologist. He has been associated with the AMRI and Fortis. He has been leading the fight in West Bengal from the front in planning, training, and providing critical care to COVID patients. In addition to all this, he has been associated with several national and international societies. Dr. Sumit Sengupta, we are all ears to listen to you. Over to you, Dr. Sumit Sengupta.
Thank you. Can you hear me?
Yes.
Can you hear me? Yeah. Okay.
Yes.
Right. Thank you for the kind introduction. I'll just jump into it with a bit of an example of what I do. I am a respiratory physician, and I spend in normal times about 50% of my time on critical care helping my intensivist colleagues. And we are a small hospital, and from April 8th, we were designated as a COVID center by the government of West Bengal. And we started out with 28 beds. Now we're up to 62. Now, for the last couple of months, all these beds are full. At any point of time, if one patient is discharged, another patient comes in almost immediately. There's a list of patients waiting to be admitted. And what has happened also is that previously to get more equipment for advanced respiratory support. The number of less ill patients are not being admitted very much to our institute. I will not talk about the medical aspects of it, but I will talk about what I and our team and everybody in our hospital do to try and prevent healthcare workers from getting infected. There are some lessons to be learned for non-healthcare workers as well, and it's important to put it into perspective of the public health, which Shankar will be talking about later, I presume. Now, we go into these ward rounds after donning and doffing personal protective equipment, which I'm sure you've seen a lot of in the public fora, and it's basically masks, and the rest is hand care, gloves, or whatever it is. For people like us consultants who really are not, doing interventional procedures on these patients, everything else is just splash proof. Anything which splashes you shouldn't be there. That's why we wear caps and foot covers and gowns and stuff like that. But actually, the most important bits are the gloves and the masks. Now, inside the COVID ward, we have intensive care, people on ventilators, being all sorts of things being done to them. We wear N95 masks, which I'm sure you've heard about. They are very good at filtering almost 95% of particles, including the virus. Outside of the COVID unit, we do not wear N95 masks, except in special circumstances. We wear surgical masks. And our hospital, I'm sure most hospitals have a policy that everybody who enters the hospital has to be masked. So we are treating every person who walks into the hospital as a potential COVID. Now, contrary to what has been said in the press, we are now in community spread of COVID, which means that everybody should be possible COVID patient. Shouldn't stop you from doing anything you're doing, but you should treat everybody as a COVID patient. So what are the things which I do and which you should be doing as well? First thing is, both you and, in our case, the patient or the person you're interacting with should be masked. Ordinary surgical masks or cloth masks are okay. In situations like a COVID ward, we use an N95 mask. That is absolutely essential. And unfortunately, it needs to be said and underscored, because this is not done. Even when you're sitting down to have a cup of coffee with your colleagues, that is the time when you're likely to get hit by an infection more than when I walk into a COVID ward. Because at that point of time, you will turn your mask down. And one of the people whom you're talking with might have COVID. As you've just heard, a substantial proportion of patients are asymptomatic or, let's say, minimally symptomatic. So you don't know. They don't know either. So at the current time, everybody whom you interact with COVID, that's how you should set your mind. Apart from the mask, the other thing which you should do is hand care. Now, gloves we use as medical practitioners, but remember, we are using it, we chuck it away after each contact. Using gloves for general public is not recommended because it potentially increases the risk of infection. The virus tends to stick on that and you forget that you're supposed to wash your hands or use hand rubs. So hand rubbing is paramount for every contact with anything that you have. So masks and hand rub, and if you use gloves to be changed after each contact with a potential source. There are other clinics, 12 by 10. I wear an N95 mask because it's a centrally AC place and you've got respiratory patients walking in. Some of them will have COVID, and I use an N95 mask. But the other thing which I've done is I've shifted the chairs away from immediate across my desk to some place which is at least 6 feet away. So people, when they sit, they are always 6 feet away. No exceptions, right? And there is a structured entry into our hospital. So that's a structural thing which you can do. There is screening. If you have got fever and cough, you're asked not to go to emergency for whatever things they will look at. If you don't have fever and cough, then they come to my outpatients, they fill up a history sheet in the waiting area, and they send in all their papers. I sit, look through all the papers and the history sheet. By doing this, I do almost 80% of the work. I know what I'm going to ask the patient. I know what examination I need to do. So the time spent with the patient. So you've got the temporal limitation and the distance limitation. So time spent with patients, they walk in, I said, okay, this is what I've gathered from your history and from your previous records. So this is what I need to ask you. They answer my question in a minute or two. Then I say, have a seat outside. I will write down your prescription. My secretary will explain it to you. So the contact time with patients of mine are minimized. This would normally take half an hour with the patient sitting inside the room. Now we have 5 to 10 minutes with the patient inside the room and 10 minutes before and 10 minutes afterwards. So that sorts out 2 or 3 things which we could do: the distance, the time spent with the patient, and at the current context, everyone who I see, I assume, is COVID. So you need to get on with it, but also be aware that you can catch it from people who don't know they have it. Of course, one of the major problems is that pre-symptomatic and asymptomatic patients will pass it on. Time spent in a closed room with a person who has COVID is the most important determinant of how you are getting the thing. And of course, if you live in the home with somebody who's got COVID, you're very likely to get it. There are other instances where these things are not adequate, and they are very specialized medical areas. For example, when you put in a tube into a patient's lung when the patient is very unwell to connect to a ventilator, that is called an aerosol generating procedure. Little sprays which float in the air. That happens in intensive cares and emergency departments. Then you have patients getting an endoscopy, which is very often done in very limited settings in India. Endoscopy is a huge aerosol generating procedure. There you need to have splash proof, you need to have face guards, as well as N95 and all sorts of things like that. In the nursing aspect of it, you must remember that if people are giving mouth care or they are suctioning a patient, which nurses do to almost all elderly people everywhere in the world, these are aerosol generating procedures. They tend to actually create the disease at more distance, even if you're not spending time near the patient so much. And of course, professions like dentists and ENT surgeons who have to go very near the oral cavity and have to look into it very, very carefully are at very high risk. They are quite aware of that, and they wear all the personal protective equipment as is required. Now, as per guidelines from the beginning, we were lucky enough to have enough personal protective equipment for our healthcare workers. We have over 1,500 staff, including doctors, nurses, other carers, and ward staff, and everybody. We've had 90 healthcare worker infections in the last 6 months. And just to underscore a point that not every COVID disease leads up to ventilation. None of these 90 even required oxygen, right? So most of them are, to me, they are quite young. A couple of people who are above the age of 60, maybe a few in the 50s, the rest are 20s to 40s. So it is, in most cases, very, very innocuous infection. Perhaps 1 in 100 will die from it. But those people who do get the disease are very difficult to manage. And we end up in all sorts of things: oxygen, then stage respiratory supports of various sorts, high flow oxygen, non-invasive ventilation, invasive ventilation, ECMO, all sorts of stuff we do. But there's a law of diminishing returns. The more support you need, the less chance the patient is going to make it. And Dr. Dhaliwal already mentioned that we are giving steroids to patients. But you must remember something, because these steroids, dexamethasone, Decadron, is available over the counter in India. Tablets are available. They actually can harm you if you are not hypoxic. If you use it too early in a viremia phase, they can actually kill you. The evidence suggests that only in the second phase of the disease, the inflammatory phase, it is helpful. Before that, it is likely to cause harm. And it's certainly not something you should be using at home at all. One of the differences between the UK and India is that we don't have a national health system. So we do not encourage people to have oxygen at home because we do not have the infrastructure for people to be checked out and picked up when they are getting worse in doing that. So if you think somebody needs oxygen, either you've checked with an oximeter, which is now ubiquitous, or the patient is breathless, particularly breathless on exertion. That probably predates low oxygen levels at rest. You should advise the patient to go to healthcare providers and hospitals, not try and give a little bit of oxygen and try and sort things out. Now, most people who require oxygen will improve, but it is not a good idea in India in the current situation to try and treat patients at home with oxygen. There may be exceptions. Perhaps you have a 90-year-old who doesn't want to go to hospital and you are quite comfortable assessing that, but that is a sort of unique perspective. In general, this tendency to give a little bit of tablet steroids and put a little bit of oxygen onto people at home is to be strongly avoided if at all possible. Now, I appreciate that not everybody will have access to healthcare or to hospitals, but that is something which you need to try and see that. Now, because of this, we tend to admit patients a bit earlier than one would do in a place with a good health infrastructure. So we want to make sure that the patient who says, oh, I was a bit breathless yesterday on walking, in 3 days' time doesn't become seriously ill. The reason is that by the time he's seriously ill, it will take some time to get him a bed, and he may not have that time. So it's earlier. If you are breathless on exertion, we encourage people to get bed. It will take a day or so to locate a bed and to get him in. And then maybe 3 days down the line, we say, okay, it's not really a problem. You don't require any oxygen, you're fine. He goes home. But if you wait till the patient is really ill, it takes time for the bed to be generated, and you have to, try and sort out a higher quality bed. And that time, that patient at that point of time will not have. So you need to react a bit early and get admitted if there's any sense of breathlessness. Of course, it doesn't only affect the lung. So we have patients with heart attacks coming in, which they have COVID as let's say, a complication to some extent of COVID. And also you have strokes and other thrombotic events, which we are seeing. So that would be a separate entity of its own. There is a problem with public transport in India because, as you know, we travel in jam-packed buses and trains. And it is going to be very difficult to open up Indian public transport because of that. In the context of let's say an aeroplane flight, which is much more organized, the risk actually during the flight is less than what the risk you have in going to the airport and interacting with people in the line and people across the desk and people in your queues. Inside the plane, the current evidence suggests the risk is not that much. As long as you're masked, as long as the planes follow the standard air filtration techniques which they're supposed to do. Traveling in trains in India would be very difficult because, as you know, we travel almost one on top of the other. So maintaining any sort of distance of any sort is almost impossible. So that is a problem in opening up Indian, because you need to have transport, suburban places. Now, the other issue to be said is that the numbers you see in the papers every day, they do not reflect actual life. You see, almost 70% of Indians don't have any access to any sort of COVID testing. What you see in the media is only the urban bits of population. For example, a district in West called Midnapur has only one COVID testing center. It's got lakhs of population. And this is mirrored all across the country. I'm sure it's the same in Assam and everywhere. So the numbers we are testing are hugely low as compared to the amount. So don't believe the numbers. They are in itself an inadequate example of what is going on in the community and in the rest of the country. The problem is when you start getting really unwell with it, and we have an antiviral which Dr. Dhaliwal mentioned. It's not brilliant. It's called remdesivir. We are giving it to most people when they can afford it, and we have access to it. Steroids have been given to everybody who has got low oxygen levels at a certain level. A couple of other experimental therapies are being tried in various places, and we have access to a couple of those. We're using that. We're not yet sure that they are really benefiting the patients, but it's something which is accepted as being maybe useful, and you have to use it very sparingly, but with a lot of thought. The other issue which I would like to say is, what do I do when I go home? Now, that is a very difficult question to answer. One of the greatest fears one has is that you pass it on to your elderly relatives and they end up on an ICU in a ventilator. Now, this is, it is not preventable entirely. However, the important thing is to have a routine. And the routine obviously includes in people working with COVID, when they go home, is they hand wash or hand rub at the moment they enter, take off all the clothes and have a shower, and try and isolate yourselves as much as possible from vulnerable people in your home, elderly, people with diabetic, particularly uncontrolled diabetics. A point there is that Dr. Dhaliwal spoke about the risk factors. Obesity and hypertension is obviously the two very important risk factors. But in India, we are finding almost all the patients in ICU are diabetic, almost all of them. And most of them are pretty poorly controlled as well, which is probably a reflection of the state of the metabolic syndrome and our body habitus and stuff like that. But being a diabetic in India is something which you need to be very careful about, maintaining social distancing and stuff like that. In the positive aspect, casual contact with somebody in the streets who's less than, you're wearing a mask and he's maybe not wearing a mask or not wearing a mask properly, is very unlikely to give you the disease. And particularly open spaces are least likely to give you disease. Closed spaces, rooms, offices, buses where you're almost stacked on top of each other, or train compartments where you're stacked on top of each other, where you really can't maintain social distancing, and masks, if worn, are not worn properly. That is the other point which I would like to emphasize, is wearing a mask has to be done properly. It should cover your nose and your face, and make sure that you're using the right mask and cleaning it if it is cleanable, and throwing it away if it's disposable. Using disposable masks for a long time without chucking them away, it actually increases the risk of infection. I think I'll stop there, giving a bit of idea about what we are facing and what we are doing. I hope that is helpful.
Thank you, Dr. Sumit. That was really wonderful of you to enlighten us. We will have more of information during our interaction session. Our next resource person is Dr. Sayantan Banerjee. He is a DM in infectious disease and has a lot of experience working with the various outbreaks. And not only that, he is associated with the ICMR. Over to you, Dr. Sayantan.
Thank you. Thank you, Professor. I hope I am audible. And am I visible?
Yes. No, your video is turned off.
I don't know why is it happening like that, because the camera and everything.
Please go ahead. Please go ahead.
Okay. Sorry for the video part.
No, it's working now. Thank you.
No,
please go ahead.
It will stop working soon. This is the thing that's happening. Yeah. Sorry for the video part. So thank you for inviting me.
Shantan, you are just too good looking, and the camera is shy of you.
Thank you for your comment. Yeah. So I have been asked about a few questions before this talk started, and I will go to those questions on vaccines, on whether we can go to job right now or not, or the list of questions that have been sent to me. But I would like to emphasize on a few things which we are facing in India, which is quite unique in contrast to the UK experience that Dr. Dhaliwal has suggested. In India, if you see the dynamics of the disease spread, the initial cases were the initial imported cases, mostly imported from China, Thailand, Singapore, Italy, Iran, and the Middle East initially. What happened is there was an accelerated governmental response to try to track down the contact persons of the initial imported cases. But what we missed initially is tracking down the invisible contacts. I will explain what I mean by invisible contacts. What happened is India went into an early lockdown on 24th of March. And we presume that by lockdown, it's equivalent to physical distancing or social distancing. But what we missed is we actually tracked many of the contacts of the initial imported cases, but we failed to track down the housekeeping staff of the airports, the housekeeping staff of the flights, the housekeeping staff and the cleaners of the hotels, our domestic maid servants, the Ola, Uber, and cab taxi drivers who used to carry these initial imported cases for almost an hour or more from the airports in the closed cabinets, in the closed cabs. We missed to track our commercial sex worker sisters, and we missed to track a lot of our invisible service providers, social service providers, who actually all come from the urban slums or come from the densely populated lower income group urban residential clusters. Like in Mumbai, we have Chawl and Juggi Jhopris, and in Calcutta and Delhi, everywhere there are slums and compactly populated lower income group residential clusters. What happened is after the lockdown was announced by the government, all the people got trapped inside their houses. And the physical distancing was actually happening inside the upper middle class urban population who has an adequate indoor floor space per capita. But the physical distancing was actually absolutely not happening inside the slums. I was working with the people in Dharavi, the largest slum of Asia. We have wonderful people's representative from Dharavi, who is also the Minister of Education for Maharashtra. And we were working with her and some other non-governmental organizations. What we found is that during the lockdown, before the lockdown, when the bathroom clusters, there are clusters of bathrooms at the end of the lanes in some of the places in Dharavi. Before the lockdown, when there were about 50 to 100 people queuing for going to the washroom in the morning, after the announcement of lockdown, this number has increased to almost 200 to 400. What happened is, actually, there are a lot of people who used to use the bathrooms of their workplaces, in the hotels, in the airports, in the big government offices, where they used to go and work. And this didn't happen. After the lockdown, they were forced to use those bathroom clusters. After the lockdown, the physical distancing was a complete dream in the urban slums and chawls. And over and above, initially we had a response which was led by the police forces in many parts of our country, because of the sole reason that there were incidents where people got scared of coming out with their diagnosis, because there were incidents of forceful quarantining into community quarantine facilities, which were perceived to be unsafe, which were perceived to be not transparent enough. We had media reporting of community quarantine facilities where food and water was not in adequate supply, where communication with family members were barred. So these are the initial reflex responses that happens in a large and diverse, multi-ethnic, multicultural country like India at different pockets, which led to a fear among these people who live in the lower middle income group, residential clusters and slums, to come out and volunteer for testing and diagnosis. That led to the initial spurge of cases inside the slums and the highly populated dense areas. The problem that we faced, the problem that we have done to these people, our brothers and sisters, is that we have failed to come up with a humane-faced system with the confidence of the community. Hence, initially, we failed to diagnose the people who were maximally at risk and who were transmitting maximally. Now, after the community transmission has been established, and now as we are going through the lifting of the lockdown process, people are coming out and people are mixing, and it is becoming really difficult for preventing infections. As Dr. Sengupta has rightly told, that when our public transport system opens up, it would be a real disaster, and probably there will be nothing else that can prevent a disaster happening other than a vaccine. I'm sorry to be pessimistic, I'm sorry to be skeptic, but in a local train in Mumbai, in a metro train in Delhi, or in a public bus in Calcutta, in the humid and hot climate, the sweating mask, the moist mask, most of us are not being able to use the triple layered fabric masks that has been advised by WHO. That's the best that you can have in the community setting. The mask should be absorbent inside with a cotton layer, should be hydrophobic outside, and in middle it should have a non-woven layer. These triple layered fabric masks, most of us are not being able to use. Medical masks are short at supply and often is inadequate in a crowded and cramped, hot and humid climate area where you are sweating and your masks are getting wet, and the physical distancing is absolutely impractical. So in this particular setting, I don't think any of the standard public health advisory is going to work. So the best thing that you can do, so what is the best thing that we can do? The best thing we can do is, right now, accelerate the vaccine procedure, accelerate the vaccine approval process, which can be done. I would just explain how. And number two is save the most vulnerable people. We have to understand, as Dr. Sengupta said, that 94 of 100 people infected or even more will not enter into the ICU at all. Almost 90 of the people infected will not require oxygen at all. And the people who are dying, who are ending up in the ventilator, are mostly predictable. Till now in India, we have a few cases where young and people without comorbidity have suffered, but those are mostly due to prothrombotic, procoagulant and the thrombotic events, and less from the ARDS and the hypoxic events. Okay, that's another problem is we are also not getting a very age stratified and gender stratified data of mortality and morbidity from the governments. We have to rely on the published reports, which is really a difficult thing, considering the load of the patient service that our system is facing. So, in short, what I would like to say is, in India, before COVID-19 has come, between 2015 to 19, all-cause mortality of mechanically ventilated patients due to ARDS was almost close to 50 to 60%, reported from the best hospitals in India. So that percentage has not changed yet now with COVID-19. So basically, if a patient enters into the ICU and is ventilated, mechanically ventilated, it's very difficult to reduce the mortality rate below 50% as of now, as per the Indian scenario is concerned. So we have to target people before entering into ICU. Okay, so in short, I would say, number one, the vaccine pathways need to be accelerated. You asked me about to explain about the vaccine scenario right now. Right now, there are hundreds of vaccines that are being developed, but I don't see many of them being able to help us within the next 6 months, suppose. The vaccines that will be able to help us in the next 6 months are those that has entered into the phase 3 trials. And in India, the vaccines that are available, stockpiled with us, that has entered into phase 3 trial is only one vaccine, that is the Oxford University's Shadox-1 nCoV-19 vaccine. We have 1 billion doses already prepared by the Indian company Serum Institute in Pune, ready to be either discarded or deployed. If it is found ineffective, they will discard it. If it is found effective, they will deploy it. Already ready. And the other Indian vaccines, Bharat Biotech and Zydus Cadila, are in phase 1, phase 2. So until unless there is a phase 3 trial, we don't expect those to come up very quickly. The other vaccines that have entered the phase 3 trial in US, the Moderna and the Inovio vaccines, they have not yet pledged to make their vaccines a global public good. So we are not very sure whether they will be affordable for the general population, the poor people across India and other Southeast Asian countries. So till now, I rely heavily on the Oxford vaccine, which is being produced by the Serum Institute. And I believe that for fast-tracking the phase 3 trials, a human challenge trial that has been advocated by the godfather of vaccines of recent times, Stanley Plotkin, and Professor Adrian Hill, the director of the Jenner Institute, can actually fast-track the vaccine very fast. Other methods can be rolling out of the vaccine in large-scale phase 3 trials, even if using historical control instead of using randomized control for the high-priority groups in the forefront of COVID control, like the healthcare workers, the police persons, the low-paid hospital workers, that is the hospital domestic housekeeping workers, and a ring vaccination strategy that was followed during smallpox and Ebola. That is the caregivers and the people surrounding clusters of COVID-infected cases. So I would stop here. I won't speak much. I would only respond to the questions next, and I would request you to see if the camera works. Everything is fine from my side. Yep.
That was a very nice piece of talk, Dr. Sayantan Banerjee. Thank you very much. Next, we have with us Dr. Satadal Saha, MBBS, MS, FRCS. He is the Director of School of Medical Science and Technology at IIT Kharagpur. He is also the Director of School of Skills, Allied Health Sciences, and in addition, he is the founder of JSV Innovations. We are all ears to listen to you, Dr. Satadal. Please.
Thank you. I will only speak for a brief few minutes, not on the subjects that Kev, Sumit, and Sayantan have already talked about, because frankly speaking, on SARS-CoV-2, they are true experts. I'm not. I trained as a surgeon. I'm not a physician. So my comments will be more directed towards concluding the session. I will allude to 3 points. First being, life, work, studies, and research in the context of IIT Guwahati needs to get back to normal. We're not dealing with children in IIT. These are all 18 plus students. PhD scholars are even more senior, and then there are faculties. I understand there will be an occasional errant student, but the rest are adults. You heard all the specialists speak, and they say that 90% of those affected with SARS-CoV-2 would not even need oxygen. Very few will enter into the ICU. And we have seen from the global experience that deadliness of the virus is somewhat on the wane. ICU admissions are down across UK, US. Mortality is also down. And now is the time to open up in a responsible manner, following rules. One has to remember that even non-smokers get lung cancer. And the 3 things that will be important while we open up, one of the reasons why so many healthcare workers contracted the disease is the lack of training and discipline. Even if you see a zebra crossing, an Indian will cross the road just next to the zebra crossing and not on it. If an Indian sees that the light is red, but he sees no car coming, they will run across the road. So we start train people. Every individual needs to be trained in planning for protection to himself or herself and protection to others. It's very simple training. They need to be told that you need to follow discipline and not behave in an erratic manner. And we need to empower them with digital monitoring solutions. If these 3 are done, let's open up. This was going to be my first point. My second is that IIT, my association with IIT Guwahati over the last 2.5 years, I get the feeling that it's a very aspirational institution where one of the current focus is to become a center of excellence in technologies for health that will usher in health for 1 billion people of India who do not have access to healthcare today. And these technologies will include devices, software solutions, delivery models, and these will impact the health system on education, public health systems approach, and treatment. This is my understanding. This is what I have absorbed from my interaction with various people and some of the steps that you have actually materially taken on the ground. To build this, we need a marriage. Normally, marriage happens between 2 people. So one side of the marriage is the center of excellence in engineering and technology. And the other party to the marriage is the center of excellence in life science, medicine, public health. I put 3 things together. Medicine by itself is incomplete unless there is a deep science, life science that contributes and a public health that disseminates. You already have the first center of excellence in engineering technology. You need to build the second, and that's going to take some time. It's not going to happen in one day, it will take 5 years. But the building blocks I can see are being put in place in a systematic, planned manner. Lastly, I will conclude by saying it is very unfortunate that the pandemic, with its exposition of deep inequities in health systems, with its catastrophic consequences on human lives, human minds, and human prosperity. Why did we need such a large-scale human tragedy to wake us up? But this, in a very distorted sense, there could not have been a better catalyst than this to stimulate institutions of eminence like IIT Guwahati to step into health systems and build center of excellence by marrying engineering excellence with life science excellence. Thank you.
Thank you, Dr. Satdar Saha. I now request Professor Deepankar Bandyopadhyay to start the discussion session.
So the floor is open for now some of the question answers. So I request, I see now we have about 90 participants along with us. So please raise your hand. You know, the initial remarks are already there from the dignitaries and experts. Now, as I see your hand raised, you know, I am going to request you for your question. So as just to initiate the discussion, so Kevin is silent for so long after this initial, you know, extraordinary, like, you know, description about this lung imaging and all. So my first question is to him, that what are the typical symptoms of COVID-19? Like when one should be, like, you know, a bit careful that these are the initial symptoms of COVID-19.
So, as we mentioned, the most common presentation is not to have any symptoms, completely asymptomatic. So many people, the seroprevalence studies have shown, they've realized they've had it, but they never knew they had it. So that's the first thing. So the other speakers have discussed that. Otherwise, the symptoms that we're all becoming more familiar with are dry cough, fever, and also lethargy, fatigue is a really common symptom of COVID. And really, we define the COVID presentation in two phases: the early viral phase, secondary inflammatory phase. But the cardinal symptom or the worrying symptom is really often happens in week 2, which is breathlessness. So developing in those few patients that we discussed, early onset of breathlessness, especially not when you move around minimally. So they're the main symptoms. But again, remember that 90% of people have no symptoms whatsoever. And even if they do, they could be very, very mild, just as a slight feeling of tiredness or fatigue. However, interestingly, what we're seeing now in the UK is something called post-COVID syndrome. And I'll also just mention this quickly, that many patients are developing persistent tiredness and lethargy after just having mild COVID. So we weren't aware of that before, but we're now seeing that. So again, so COVID by itself may not just be an acute disease, it may be a long, protracted illness in some patients.
Thanks, Dave. Swami, you have raised your hand. Professor Swaminathan?
Yes, please.
Please go ahead. Please
yeah,
go ahead.
My question is about the vaccine. Is the vaccine going to be effective on an elderly person, say above 60 years of age, compared to, say, a young person? Equally effective?
Okay. Should I proceed?
So, Dr. Banerjee, yeah, Dr. Banerjee.
Okay. So, by the efficacy of a vaccine, we typically mean, in modern times, we typically mean that how much cases the vaccine is actually being able to prevent. So what we do is, in a phase 3 trial, first a vaccine candidate is developed, okay, and then it is tested on animals, and it is shown to have developing antibodies and preventing infection. Then it is tested on maybe non-human primates, and then it is tested on a very handful number of individuals to show its safety, which is called a phase 1 trial. Then we have a phase two trial when we involve more number of individuals to see the safety as well as the correlates of protection. You have to understand what do we mean by correlates of protection. Correlates of protection means those biomarkers which shows that if this is present in your body after the vaccination, if this thing can be tested, it is equivalent of you being protected. The problem with a new disease is we often do not know whether a high level of antibody, despite of after the vaccination, if there is a high level of antibody response, whether that high level of antibody is going to protect you or not, that is not very clear for a new disease. Suppose we take the example of an old disease that we quite know of. Let's talk about hepatitis B. For hepatitis B, if you have a vaccine which gives you a surface antibody response of a titer more than 10 international units, it is known that that will prevent you from acquiring a hepatitis B infection until unless it has a specific mutation. Okay. So for this, okay. So for a new disease, we don't know whether this high level of antibody is actually going to. There is the echo feedback. I'm sorry. Yeah. Yeah, it's better now. It's better now. Yeah. So for a new disease, we don't know whether a high level of antibody is actually going to prevent the disease or not. Like in HIV or in hepatitis C, which is another hepatitis, the high levels of circulating antibodies does not mean that these are neutralizing. And throughout the life, you can have high level of antibodies and the virus existing together. So for COVID-19, it is presumed that with our history of other coronaviruses, that probably an anti-spike antibody and an anti-spike T-cell response will actually prevent the disease. But we don't know till today, until unless a phase 3 trial is done or a human challenge trial is done. That means in phase 3 trial, suppose thousands of people, volunteers are vaccinated and thousands of volunteers are not vaccinated, control arm. And they are observed over for a few months. And both are presumed randomized in such a way that both of the groups are presumed to have similar risk of community exposure. After that, we again revisit the population and we see how many people from the vaccinated group are infected, how many people from the non-vaccinated group are infected. If we find a statistically relevant difference, then we say that the vaccine is working for preventing infection. For certain vaccines, like pneumococcal conjugate vaccine or the BCG vaccine for tuberculosis, we see that the vaccines do not prevent primary infections, rather that can prevent severe disease due to the pathogen. Okay, so if we see that with COVID vaccine, the rate of infection between the control arm and the test arm is not different enough, but the vaccine arm is not having significant number of severe disease, but the control arm is having significant number of severe disease, then we can say that this vaccine is not a preventive vaccine, but is actually preventing serious adverse event of the disease. Okay, now I come back to your question. For COVID-19, we don't know the correlate of protection. We don't know whether the antibody response or the T-cell response will actually save us from the disease or not. But we are having a significant antibody response and T-cell response published in the Lancet paper from the phase 1, phase 2 study of the Oxford vaccines. When I come to your question, you have asked that above 60 years, will the vaccine work? So whenever we have patients who are having low immunity, either due to extremes of age, a very small neonate, or a person who is in the 80s or more than 70s, definitely there is waning of immunity. If a patient is on corticosteroid or other immunomodulators, or the patient is having some kind of malignancy or cancers, okay, and many therapies are there which can lead to reduction of vaccine immunity. But there is also this chronic kidney disease and dialysis, which also reduces vaccine immunity. But there are certain ways of dealing with that. One of the commonest way of dealing with that is to administer booster vaccines in more frequent intervals than that is done for the individuals. But till today, what I can say is we don't have enough information on the correlates of protection. Yes, the vaccine produces enough immunoglobulin response and T-cell immunity above 60 years as well. And if booster dose is given, if we talk about the Shadox vaccine, if booster dose is given at least for 2-3 months, we don't have experience more than that. For 2-3 months, there will be adequate antibody response, but that does not mean that it will prevent the infection. Thank you.
Thank you very much.
Thank you. Thank you, Dr. Banerjee. Basanta Ranjan Borua, Professor Basanta Ranjan Borua from Physics Department. Please go ahead.
Yeah, my question is related to herd immunity. So perhaps Dr. Sayantan can answer my question. So I have heard that for herd immunity to work, some 50 to 60% population should get infected. But after that, it is assumed that rest 40% will be safe. So this is not clear to me how 60% people getting infected will make the other 40% safe. Is it that other 40% will be remaining inside home? That is why they will be safe, or?
Okay. So first of all, I would like to say that in a country like India, where we have a very significant number of, as Dr. Sengupta was telling, where we have a significant number of young diabetics, young hypertensives, and lung disease patients owing to smoking, indoor air pollution due to the fossil fuels, and outdoor air pollution. It is a scary situation to have a 60 to 65% infection throughout the population in order to achieve herd immunity and prevent infection. It's a scary situation, believe me, because out of the 60% population, if we have a 2 to 3% mortality, that means we are talking about like out of 130 crores, we are expecting 70 crores to get infected and 1.4 crores of people to die. So I believe that this is not a very good assumption. In UK, initially the UK government and the UK Prime Minister thought that herd immunity will protect us, but global leaders across has come out across it. And now coming specifically to your question, yes, if there is 60% of people who have enough antibodies and are not getting infected again, it will break the chain of infection. If you see the rates of seropositivity that are being published at different forums, you will see that in the Geneva study, in the US studies from US and India, the rates of seropositivity is much high in the age group of 25 to 64 than people below to age of 25 and above age of 64. That is because this age group between 25 to 64 are those age group which is maximally interacting with people, having social interactions. So if majority of these people who are having social interaction and is capable to transmit the disease becomes immune to the disease, then the disease flow dynamics will fall down. That is the main reason telling that herd immunity will protect. Actually, herd immunity of the young and less vulnerable population will protect the elderly and the more vulnerable population by reducing the disease dynamics. That is the concept. Thank you.
Thank you.
Professor Mohanty. Professor Mohanty, I see you have raised your hand. You have a question?
Yes, can I?
Please go ahead.
Yeah, so good evening to all the panelists, and thanks to all of you for this very nice and elaborative talk. My question is a very simple one, which will be there in many of us mind. Is there any specific restriction or precaution required for those who are diabetic and or hypertensive?
Dr. Sengupta, I mean, you are silent
Yeah,
for long, so maybe
yeah,
he's the best person to answer. Yeah.
Yes, yes.
Right, I'm here. If I understand the question correctly, are you saying that diabetic people have some special things to look forward to? I would say no. I mean, there is no special sort of precautions a diabetic can take, apart from one thing is to actually correct the diabetes and control it perfectly, which most of us are not really willing to do. But now is the time to get rid of all the extra flab and get a workout and make sure your HbA1c is well under control. The disease dynamics or the spread of disease is no different from anybody else. However, if you get the disease, your chance of getting severe disease is more. So getting the disease will be basically the same. Precautions you take will be the same, with just one added factor is that you try and control your diabetes as best as possible.
Okay, thank you. But Dipankar, can I continue and?
Please go ahead.
Yeah. Any?
Hello.
Please go ahead. Hello. Please go ahead. Perhaps his voice is lost. Dr. Borua, Dr. Anuj Kumar Borua, he has raised his hand.
Any?
Thank you.
Dr. Borua, please go ahead. I will get back to Mohanty later once his voice becomes okay.
No problem.
Okay. Thank you, Professor Banerjee, for arranging such a nice webinar. At the time, thank you, Professor Kevin Dhaliwal, Dr. Sumit Sengupta, and Dr. Sayantan Banerjee, as well as our old friend Satadal Saha. Actually, my first question is regarding is there any relevance of CT value, cycle threshold value in that is RT-PCR test? And my second question is, what is the implication of antibody test? Is it the right time to do antibody test now in India or especially in Assam? So these are my two questions.
So just to introduce him, he is our doctor, inside campus. So our health is all dependent on Dr. Barua. So maybe, so Dr.
Okay, sorry,
Sengupta,
I
Dr.
introduce, sorry. Okay.
It's okay. Dr. Sengupta.
I can talk a bit about the CT values. See, CT values is basically dependent on the machine and the system you are using. So you cannot extrapolate one CT value from one set of machines to another. However, we are using CBNAT, which has the same machine all across the country in TrueNat or in Cepheid GenExpert. So there the CT values are approximately equivalent. There are two problems with that. One is there is a huge amount of sampling error. A person who's got a very well done sample from the nasopharyngeal area and somebody who's got just a Namka Vaste swab will have different CT values with the same amount of disease. So you can give just broad generalizations about the CT value and the number of virus particles there. Secondly, during the phases of the illness, we are actually seeing patients who are negative to RT-PCR while they are in ARDS. So the severity of the illness doesn't correlate definitely with CT values. Perhaps the only place where it could be of value is if you're looking at infectivity of patients who become asymptomatic. But you cannot compare apples and oranges. You can't compare an RT-PCR, say at IIT Guwahati Medical College and an RT-PCR in Delhi, unless you're using exactly the same machine, which is only true for things like Cepheid GenExpert or perhaps TrueNat, which is the other Indian version of that. I would really not go with CT values very much to help clinical decision making. Maybe infectivity, but again in a research perspective. And for point of view of antibody testing, really it is no use in an acute diagnostic sense. somebody's come with a cough and cold, or somebody's got a contact of somebody who's got cough and cold, I would like to get a definitive answer, and that would certainly not be antibody test. It is very useful, and we are using it in healthcare workers, people at high risk, to see how the disease has spread, assuming it to be a surrogate for number of infections and efficacy of personal protective equipment and what the current scenario is. And it's also obviously very useful for epidemiologists to track disease in various populations. For clinical case management, an antibody test is really not very useful.
Thank you, Sengupta. Actually, recently in our campus itself, we got a case actually. One professor, then his wife and daughter, all of them are tested positive. No, doctor and wife having CT value of 14, symptomatic, but the professor himself is CT value is 29, but totally asymptomatic. They are undergoing in a home isolation now. That's why I'm raising the question. Thank you for your answer.
Thank you. So I'm coming to every one of you one by one. So one question is from Dr. Raghavendra Gupta, and I float it towards Kevin, that how vulnerable are the kids, campus kids? How vulnerable are the campus kids? This is one question that has been raised by one of the professors. His name is Dr. Raghavendra Gupta. So how vulnerable are the campus kids?
Yeah. So just again, as we mentioned before, any ages can be infected with SARS-CoV-2, but typically young people remain very asymptomatic, so they're all susceptible to infection, but how many of them are vulnerable to COVID-19 disease is a different question. And when we look at the data that's emerging, it'll be a very small percentage that will develop symptoms and then also severe disease. So their biggest risk is, as colleagues mentioned, is transmitting the disease to other vulnerable people rather than themselves developing disease. So they have a social responsibility to socially distance, to think about infection control, thinking from a public health perspective. So they are as likely to catch it as anybody else, and if not more. We know now, as we unlock in Europe and the UK and America and other places, that actually there's a very high prevalence in the young community as they are released into freedom. So they sometimes lose the restraints they had before.
So is it the case that they cannot have their afternoon games on during the pandemic time?
They should still have their afternoon games, but I think they just have to be careful, and definitely in terms of how they interact as you undergo coming out of lockdown. No large gatherings. And the thing that is important is if ultimately countries that have tried to contain this have had a very aggressive track, trace, isolate and public health measures. So the question is on campus, to stop this spreading, if you do have testing or you do bring in testing, for them to actually then understand that they should contact trace and isolate. So they stop that and be responsible. So that's important. So I think that's the key message.
Thanks, Kate. Next, Arvind Kumar De, Maths Department. Dr. Arvind Kumar De, please go ahead with your question.
Yeah. First of all, I would like to thank the organizers and the speakers today. So my question to Kevin, first question is to Kevin. So I'm running a healthcare startup, and my question is it possible to take any partnership with the technology that's going on in Edinburgh currently? So that's my first question. My second question is to Dr. Sumit Sengupta. So as a entrepreneur, what would be your suggestion to the entrepreneurs of the country that what kind of technological development would would be very much beneficial for the doctors and the community in general. So that's my second question. And my third question to Dr. Sayantan is regarding the deployment of the vaccine. Regarding that, I was trying to build some of the technological development regarding, say, geospatial uh, uh, geospatial uh, 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 structure where the information would be provided, like number of hospitals available, number of patients available, etc. So if I saw some of the technologies available in Harvard, some similar technologies, and I was thinking that if somebody wants to build that kind of technology here in India, the main problem is the structured data is not available. So
Arabin,
I just want, yeah.
Arabin, since we do not
Yeah.
have much time, so I have more or less understood the question. So I direct the entire thing to Cave, that his major question is that technological development around COVID-19 and the possibilities, like what are the possibilities in technology development? How do you see the technology development around COVID-19?
So I think technology is going to be the biggest way to disrupt COVID-19, both in terms of diagnostics, but also in terms of public health measures, in terms of track, trace, isolate, and also novel materials that can stop the spread of COVID-19, SARS-CoV-2. So imagine that you have UV or you have SARS-CoV-2 killing materials on the public transport. You have UVC lamps that can kill the virus in aerosol generating procedures. You have a whole range of mitigating strategies, diagnostics in face masks, for instance. And then also good communication portals that highlight, spikes of epidemics, so you can enforce public health measures. So I think the biggest technological advances are made in wars. We all know that. Mankind moves fast when there's a world war or any conflict. This is now a world war, and I think technology will jump because of SARS-CoV-2 and COVID-19. So going back to the question about entrepreneurship, I don't think ever in mankind has there been a need for entrepreneurial activity as there is now. And yes, we'd be delighted to help from Edinburgh as well, but there's a myriad of things that can be done for COVID-19.
Thanks, Kev. The next question will be from Dr. Nitin Chaudhary. Can you please hear your question? Nitin?
Yes, sure. Yeah. Can you hear me?
Yeah, please go ahead. Please go ahead. You are audible.
My question is about the vaccine. So I came across some literature about high antibody titer against adenovirus in Indian population. So considering this, how likely the Oxford vaccine, which is an adenovirus-based vaccine, and I guess one of the front runners, is how is it going to work in India?
So, Kay, would you like to take the question, or Dr. Sayantan Banerjee? Maybe both of you, one by one. So, question is adeno vaccine, whether it is going to work in India or not?
Because Indian population seems to have high antibody titer against adenovirus.
Okay. Is Cave going along, or should I?
Yeah, I can answer first. Just similar to you mentioned earlier, the key thing is trials and tests. So you'll understand early on whether there is a neutralizing adenoviral antibody that stops this happening. But clearly there's the opportunity to give boosters as well. But I think it's early days. And I understand at the moment that the Oxford vaccine is trialing in Brazil at the moment, and maybe starting studies in India. So maybe in some small studies, you can find out whether that is a problem.
Dr. Sayantan Banerjee? Yeah,
yes.
Please.
So out of the 7 common adenovirus, out of the 7 known adenoviruses which infect the human beings, we have seen only 3 adenoviruses which causes severe respiratory syndrome. The one that was discovered early in 2001, that is the SARS, which can call it SARS-1 now, And the second one is the Middle East Respiratory Syndrome coronavirus. And now we have the SARS-CoV-2 or the COVID-19 virus. The rest 4 coronaviruses which are circulating in the human beings very commonly, and which are the most important reasons for the serological response, do not cause severe respiratory syndromes. So the thing is that overall, coronavirus is a large group of viruses which has a lot of feline and canine viruses also, and the antibodies till today are not found to be cross-reacting and cross facilitating the immunity. Like people who had history of SARS or MARS can be infected with SARS-CoV-2. That has been proved. And the coronaviral antibody response typically is not like the chicken virus, the varicella antibody response. It does not give a lifetime immunity. It has been seen with, maximally seen with the 229E coronavirus, that the antibody responses typically last for about 2 to 3 years, which prevents secondary infection within that. But beyond 5 years, there has been multiple incidents noted of having same infection repeated for coronavirus. So I don't think that a high level of circulating coronavirus antibody in Indian population is going to make the SARS-CoV-2 vaccine futile. And I also presume that the SARS-CoV-2 vaccine will require multiple booster doses, considering the waning of immunity and less persistent nature of the immune memory cells against coronavirus. So we have very limited information till now, but this is what I can tell right now.
Thank you, Dr. Banerjee. Now next is Dr. Palash Ghosh. Can you go ahead?
Yeah, thank you. So my question is for Dr. Sayantan. Sayantan Palash here. So my question is that how to address or detect the short-term and long-term side effect from vaccines. And if we have a very rare side effects or deadly side effect, then the problem is that we will dealing with the 2 kinds of problem, the COVID problem and the deaths related to the vaccines. So what is your take on that?
Palash, it is so nice to see you after such a long time.
Thank you.
So, yeah. And the thing is, see, the short-term, the vaccine side effects are seen in all the 3 phases, phase 1 and phase 2 and phase 3 trials. The short-term side effects are well visible in the phase 1 and phase 2 trials. The intermediate term side effects are seen in the phase 3 trials. Okay. If you see the maximum adverse events and the worst things that has happened with vaccination in the history of vaccination, those are typically due to contamination of live viruses into the attenuated viruses. If you know about the worst accident that happened with the smallpox vaccination in USA.
Yeah, that's Salk's vaccine.
Yeah, that was because of the contamination of live polio vaccine in the attenuated polio vaccine. That has happened. We have history of contamination of mycobacterium tuberculosis in BCG vaccines, but these are contamination issues. And if you see the very rare vaccine-derived polio or the narcolepsy cases happened in Europe secondary to the influenza vaccines, or Guillain-Barré syndrome, which happened quite late, or the vaccine-mediated exacerbation of the CNS side effects happened due to a mutated strain of the measles virus. These happen quite late and quite rare. So we will not have a complete idea of vaccine-related side effects, long-term side effects, even after the phase 3 trial. But now we have very safe vaccine platforms overall. the chimpanzee adenovirus platform used by the Oxford group has been tested for other viruses as well, and they have been shown to have a very good long-term adverse effect profile. So as the vaccine platform is safe, we presume that we have only tweaked the gene of spike protein inside the adenoviral vector. So the tweaked spike protein gene will not cause major side effects. That is our presumption, but only time will tell. But what I can tell you is the great help that the vaccine will do to the humanity by saving so many lives is almost absolutely non-comparable to the very rare and rarest of the rare long-term side effect that it might produce in due course because of its safety already established. Thank you.
Okay, thank you. Thank you, Dr. Banerjee. The next question is from Vinayak. Vinayak, please go ahead.
Yeah, I would like to thank all the panelists. My question is on efficacy of plasma therapy. So how good it is, and then what is its fate for this COVID? Thank you.
So Dr. Sengupta, can you please, teach us on plasma therapy?
Plasma therapy. Yeah, can you hear me? Yeah.
Yes.
Hello?
Yes, you are audible.
Yes.
Yeah, you are audible.
Plasma therapy is as yet unproven as efficacious in this disease. There have been 2 randomized controlled trials, one in China and one has been reported, I think, from in the United States, which have shown no efficacy at all. There are subgroups where, and the timing of giving up plasma therapy, where there is potential benefit, and as such, we are not sure about whether it is totally, there is total lack of efficacy. The problem with plasma therapy is that we don't really know which component of the plasma is actually going to protect a person and at what time of the disease it's going to be effective. Neutralizing titers are not being measured in most places where they're using it out trials. So I would think that one would require really good randomized controlled trials to actually tell us whether plasma therapy is beneficial, if at all it is beneficial. So right at the moment, experimental therapy only to be done in randomized controlled trials. That is my opinion.
Following another question to you only, how accurate are the testing for COVID-19? Will someone having COVID family of infection and also test positive? So the question is that, I repeat the question, how accurate are the testing for COVID-19 in a situation where someone having COVID family of infection and also test positive? I mean, there are so many different types of COVID viruses. And now you are testing
no,
and then it is...
No.
Please.
The family of coronavirus was mentioning, there's 7 of them. COVID PCR test is specific, right? Unless there is some lab contamination, you're positive. Have genome of virus in your system. Now, the first time round we're diagnosed. Now, testing to say whether you're infected or not is out of the window. You do that anymore because the tests are too sensitive to show whether when your viruses are.
Hello. Maybe we have lost some connection with him. So I just go with another question, which is to Dr. Banerjee, that activity time of the vaccine. I mean, say suppose if somebody is vaccinated, how long the vaccine will be active? And say suppose somebody has been cured after COVID infection. So how long the antibody will be there in the body?
Okay. So the first question is how long the vaccine will be active. So this question has two layers. One is, how long will be the antibodies persistent in the body against the vaccines? And second is, will the antibodies be able to prevent the infection or not? So right now, we know that the vaccines produce antibodies and the vaccines produce specific T-cell response, as published in the Lancet paper about the Oxford vaccine. It has also shown that if you revaccinate after 4 weeks, then the vaccine response is boosted and you have a very good titer of IgG, anti-spike antibodies. But as the time frame of study, because we have known the virus since the last 8 months, as the time frame of the study is short, it is difficult for us to predict right now how long the vaccine, the immunoglobulin response will stay. If you see the standard antibody response of the other coronaviruses, usually the antibody titers against the coronaviruses stay at a high level till 1 year. It usually fades off after the second and the third year. And after 5 years, the coronavirus antibodies fades off in fact most of the population. Now, it is not very clear that even if you have antibodies at a high level for the next 1 or 2 years, whether you will actually be protected or not. Okay, so you have to understand that the vaccine will produce levels of antibodies, but we are not sure whether antibodies mean protection or not. Till now, in the last 8 months of the pandemic, we don't have enough conclusive evidence to say that a high level of antibodies, despite of high level of antibodies, there is a second infection of COVID-19 happening. So presumably, we can fairly assume that a high level of antibodies may be equivalent to protection, at least for next 2 to 3 years, as the coronavirus responses are seen. So it's a difficult question until unless we have either phase 3 trial data or human challenge trial done with the vaccines. We can't say whether these vaccines are actually protective or not. Thank you.
Thank you. Dr. Shah, you want to ask some question? You have raised your hand. Dr. Sengupta is also back. So some incomplete part was there.
I just want to bring a little bit of a light touch. Any comments? And this question is for all. Any comments on the Russian vaccine?
Yep. Who is taking the question?
Yes. Any question on the Russian vaccine? Everybody looks confused. So maybe I start with Kev.
So
any comments on the Russian
vaccine? So I think given the Russians brought polonium into the United Kingdom, we don't really know what is true or not. So my only comment would be, it's a bit like the sports doping thing as well, Satadal. For 40 years they doped in sports and cheated. So I'm being a bit controversial now. I don't trust them at all.
Kevin, clean your doorknob.
My doorknob is always clean.
Clean your doorknob after the webinar. I believe everybody is getting the joke, right? About the doorknob and the Russians and the British.
Yes, yeah.
Surely. Yeah. So should I chip in for a minute? And I believe we have our Rafales ready to protect me. So yeah. So I'm not revealing my position, my geospatial location. So basically, the Russians have used the chimpanzee adenovirus vector, either whether it is a novel design or whatever. So the chimpanzee adenoviral vector has been proven to be quite safe in the Oxford studies. I'm yet to read a study on the phase 1 and phase 2 trials peer-reviewed in any journal about the Russian vaccine. So really, we can't say about that. And regarding the approval of the vaccine, the vaccine has been approved without a phase 3 trial or a human challenge trial data being published in the peer-reviewed literature. So what we can say is the Sputnik 5 vaccine that we have right now can really be a surprise like the Russian space mission. It can be a breakthrough vaccine, but the problem is I won't use it on my my family member, my son, or my kids until unless I have a strong safety and efficacy data published and peer-reviewed by the modern medicine practitioners of the world. So what we can say is the vaccine might be wonderful, the vaccine might be bad. The only information that we have about the vaccine is that we have no information.
Thank you, Dr. Banerjee. So since we are into about 2 hours of the discussion, so maybe my last question will be to Dr. Sengupta before we finish with some concluding remarks. See, there's a huge doubt in the minds of the people that, say, suppose if there is a virus in the air or in an inert place, like say, suppose this office or a chair. Now, what is the duration of the potency of that virus? I mean, how long does it survive? Outside a human atmosphere, outside a living atmosphere. I mean, so that, the panic, like if somebody gets into COVID patient somewhere or somebody is infected, there is a panic around. So before sanitization and all, how long do we need to wait in order to make sure that the potency of the virus is gone? You are not audible. Your microphone is off.
Hello, can you hear me?
Yeah. Yes, please.
I'll give you an example. I think last month, the Chinese government published data on their train system. More than 25,000 people had traveled. Remember, between the time the Chinese lockdown and the Wuhan started, more than 25,000 people traveled in what we would call the similar to a Rajdhani Express, and a huge number of people. They, as the Chinese want to do, had absolute data on everybody who had COVID in those trains, right? So if you were sitting next to a COVID positive patient, in a Rajdhani-like train the Chinese had, 25,000 people and all the data they've accrued, you had 0.15% per hour chance of picking up the virus. And after 3 hours, the risk of getting the virus exponentially increased. Their comment was this was probably an overestimate because most of the people sitting next to you are your friends and family a lot of the times. So even before you sit in that sort of chair car, as it were, it is not that casually infective. You have to really be inside a room, and mostly it is droplet infection. It does persist on fomites, and there have been several studies looking at 2 to 3 days on this and 1 day on that, but none of these have proven that they are infective at the end of 3 days. They've just shown that the DNA or the RNA you can measure the DNA 3 days afterwards. So getting infection from fomites is now downgraded. It's not one of the major routes of passing on this virus. Obviously, if you live in the same room or sort of home with a person who has, it's going to be lots of scope for fomites. But or if you work in the same office or the same room with a person 8 hours a day, 6 hours a day, you're going to pick it up from fomites. But more importantly, you're going to pick it up from droplets, which 6 feet is a sort of a ballpark figure. It can be more than 6 feet. It is not airborne in the classical sense of airborne diseases. It doesn't travel through the air conditioning system and affect different levels in hospitals or cruise ships or even any big mall. The little bit of airborne transmission which has been shown has been inside rooms with patients with known COVID. So yes, you have to rub your hands and wash your hands, but surface contamination is only done if you are living with or taking care of a known COVID patients. It is not really that useful if you do not have a known COVID patient around. And hand rubbing, ultimately, wherever it is, you either have to breathe it in through your nose, or you have to touch your nose with your hand which you've touched someplace where there's the virus. So if you hand rub, fomites are unimportant. And if you wear a proper mask, then the aerosol or the airborne spread is less. So one needn't panic about cleaning everything obsessively. Hand washing and hand rubbing are the most important, as well as masking.
So thank you, Dr. Sengupta. Thank you, Dr. Banerjee. Thank you, Kev. Thank you, Dr. Saha. For I think we are about 2 hours into this discussion with these initial remarks and all. So now I will request Akshay to conclude the panel discussion as well as the session.
Yeah.
Over to Akshay.
Thank you, Professor Dipankar. And thank you all. I am sure that everyone will agree that this has been a very eventful session, fruitful session. It has been very satisfying. It was very nice to listen from the experts, and also the interaction of the IITG community. They were able to clear all their doubts and concerns. So I thank all the dignitaries, Dr. Kev, Dr. Sayantan, Dr. Sumit, and Dr. Satadal Saha for staying with us so late and making time for us. We know that as doctors, you are fighting for us against COVID, and you have been very busy. This is your valuable time. We thank you very much. We have been blessed to be here with you. In addition, we thank for the unconditional support of the IITG community. About 90 people are still online with us. And for all those student participants and the staff members who are watching us online on YouTube and Facebook, we thank you all for your unconditional support. This webinar would not have been possible without the assistance of our able administration. Thanks to HOS Amaya Madam, Director's Office. Thanks to Pallav. Thanks to our very efficient staff from nanotechnology, Sandan. Last but not the least, we thank our director, sir, for taking initiative, helping us in planning this, and for the emotional support, unconditional support. We look forward to more such webinars, interactive webinars, so that our community can get benefited, and it would boost our confidence based on the need of the community. Thank you all once again, and wish you a very happy Independence Day. We hope that post-independence we would be hopping back to normalcy more faster than now. Thank you very much.
Thank you so much. Thank you so much. And have a nice Independence Day tomorrow. To all of you. Thank you.
Thank you. Thank you.
Thank you, everyone. Thank you. I would also like to specially thank the director of IIT Guwahati for providing support to this initiative and providing leadership to the entire efforts at IIT Guwahati. Thank you.
Thank you. Thank you all.
Thank you.
Thank you, sir.
Thank you.
Thank you. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.